Thank you very much. I want to thank the organizers, Philip and Lawrence, for the invitation, and for the Academy for focusing this day on a really important topic, which is a defining topic of our time, and I think a really important one that we need to be discussing. And I'm hoping that my talk will complement the two talks before, which is the inspiring personal story of Mintala, who shows the resilience of the human spirit, and Alex's talk that talks about the imperative of everything we do underpinning by human rights. And so today what I want to do is going to be much more technical and to try and give a framework of the health issues and health determinants of refugees and migrants. And I want to speak from the perspective of a clinician scientist. And there is some data in my talk, but also I want to speak from what it's like as a clinician to treat patients and some of the ways forward. So I have nothing to disclose. And so these are the main topics that I want to cover today in my short period of time that I have to speak, is we'll talk about some global trends. I want to go through why migration is an important determinant of health and a complex one, talk about some of the specific health disparities of refugees, what we can do in a post-arrival health care assessment and why that's important, and then a few comments about health promotion of refugees, and then that will be expanded on much more, I think, in the following talks. So, as you have all heard, that global migration, this is a natural phenomenon and has occurred for centuries. But it is a phenomenon that is increasing, and it's driven by many different factors. And so global migration is increasing, and it has tripled since 1970. But I think that why we're sitting here today and what has made this an urgent issue is the increase in forced migration, which is now at an all-time high. Of the most recent statistics of 70.8 million people who are refugees as of 2018. And this has doubled in the last 20 years. So a dramatic increase, and really fueled by conflicts. And so these are some of the images beginning when the crisis and the people pouring into the borders in Europe. And as I think everybody is very, hang on, I gotta find mine. It was this picture that brought the human face to this crisis of Alan Kurdi's lifeless body on the shores in Turkey that really catapulted this issue to the highest levels of political discourse, which unfortunately, sometimes it takes something like this to do that. And so there has been a response, and I think that this is a response that will help us at the very basic level in our own fight for promoting the health of refugees. So it was this movement into Europe of 1.3 million refugees and that picture of Alan Kurdi that really led to the first ever UN Refugee Summit in New York in 2016. That was followed by a New York declaration that Canada signed of the Global Compact of Orderly Migration. Because what makes it so difficult, and I think that was brought up very well by Min's talk, was I have 6 hours to pack up my life and move somewhere else. And I think that having orderly migration is something that is very critical to promoting health. And then this was followed by the global compacts that, again, were adopted in Marrakesh in 2018, followed by a global action plan to promote the health of migrants and refugees accepted at the World Health Assembly in May. And everybody has seen, the copies are available, that the academic community has now gotten into this issue under the leadership of Richard Horton with the Lancet Commission on migration, which I think is really critical to raise these levels to to the academic community, which we're all academics here, that we can use that privileged perspective to promote the health of migrants and refugees. So today we're focusing on a special group of migrants, refugees, and asylum seekers, and these are people who are escaping for the fear of persecution on many different grounds. This is the Geneva Convention definition, and an asylum seeker is a person who's claiming that status. And I will go through today why it's important to focus the lens on this particularly vulnerable population, because of many of the experiences these people have put them into a precarious situation with respect to their health. So let's just go through a little bit of the backdrop in Canada and where are we at. So Canada is a country that's built on immigration, and a fifth of our population is foreign-born. We receive in the order of 250,000 new immigrants per year, and just to highlight that about 10% are refugees. And so this was before the large surge. Now we're, in the last few years, this is 50,000, and previously it used to be half refugees that were accepted overseas, and the other half were people that were asylum seekers that came across the border. With the Syrian refugee inflows, those proportions have changed a bit. So this is our trajectory of proportions of the foreign-born in Canada. So you can see that a fifth of our population is foreign-born. And how about the refugee flows? So the refugee flows, unfortunately, mirror the conflicts that people are escaping from in different parts of the world. So the cohorts change over time. And so you can see in the World War II, post-World War II, most of the refugees were from Europe, and in the mid-70s were the boat people, the Vietnamese and Cambodian boat people from the conflict that was there, from Bosnia and Herzegovina, and most recently from Syria. And other people have already mentioned this, but this is something that we're actually living on a very personal level at my hospital, and the migrant crisis in Quebec, where 90% of the asylum seekers are coming through the border at Lacolle, which is 2 hours from Montreal, and the numbers have increased dramatically, and we're struggling on the ground to address their basic needs in terms of housing and getting them into productive lives, but also addressing their health needs. And one of the things that you can see is that the face of the people that are coming through have changed over time. So in 2017, the majority of the people that were coming across the Lacolle border were from Haiti because of the policies of the Trump government of removing the rights of the Haitians who had come after the earthquake to stay in the U.S. So many of them came across the border, and subsequently the flows have changed to Africans who have come for a day coming through the U.S. and then across the border, and now, more recently, people from India, Mexico coming by plane and also across the border. And in speaking to my colleagues in public health, the flows have actually not changed, and at any one time in the reception centers in Montreal, and there's 2 large reception centers, there's about 1,100 people who are in the reception centers and staying for anywhere for 3 weeks. So really quite a difficult situation in terms of managing. So how about migration? And I was asked to talk about health in migrants, and this is such a super complicated, there's so many different determinants of health, and so I've tried to break it down in a way where you can look at what are the determinants of health at different stages of the migratory path. And there are many different determinants at each of these paths that do interact. And so in the pre-arrival setting, people come with their certain baggage and whatever their biologic genetic characteristics are, what the local patterns of communicable and non-communicable diseases, what access they've had to health care, some cultural practices, and I'm sure that you'll hear about FMG later, the political, social structures, as well as violence people may have experienced prior to arrival. And so this is very heterogeneous, obviously. And then the transit. So transit can also be quite varied. It can be that you get on a plane and you go from A to B, and there really is no difficulty, but there may be transit where it's difficult conditions, where you're on a boat, where you've been trafficked, where you've stayed in very cramped living quarters, and with no access to care. And then the last is, how are people received, and what are the determinants of that, and how are people being housed, and what kind of access do they have to health care. And to add to that complexity, after arrival, this is a very dynamic process, that things change over the life course as well. And so there are many post-arrival factors, the risk factors and barriers, and then the modifiers, enablers, that we as healthcare providers and settlement agencies can provide to address and improve the health status. So some of the very important are the entitlement to care, the language and cultural barriers, stigma, socioeconomic barriers, and then some of the risk behaviors that people may have. So as a result, there's a great diversity in the health status of immigrants that's dynamic over time. So by the migration trajectory determinants, by age group, by migration class, and then how do we address in the post-arrival health setting. And this is complicated by the pre-immigration screening. So we do have a pre-immigration screening process, and for most immigrants and refugees that are accepted overseas, this occurs beforehand. But for those that are coming across the local border, it occurs afterwards. And so there is a selection, and one of the, I think, important things is that the major gap is that there's no routine post-arrival health assessment. And this pre-immigration screening exam is not for health promotion, but really is to prevent the importation of diseases that are potentially communicable, as well as will cause a health burden to the health system. So in terms of thinking about the health status of immigrants, that everyone has heard of the healthy immigrant effect. And if you look at overall, immigrants are healthier due to pre-selection and that screening process that we have. So we have a medical screening process, and then you have a self-selection of individuals that are coming in, and we also, in the economic class, pick people who have a higher economic status and educational attainment. But as we know in epidemiology, the devil's always in the details and the stratifications, and it's never that simple. So yes, immigrants are healthier when they arrive, but, and always a but, that this declines after arrival. Certain groups are not as healthy, and refugees fall among this group. And even if you look at all immigrants, that the mortality from infectious diseases, so I won't be out of a job soon, is higher in the immigrant population due to many preventable conditions. So I think this illustrates, and this was a study where from linked data of mortality data with the landed immigrant data file, that you can see that all-cause mortality is lower for all groups of immigrants and refugees. But when you start stratifying and looking at cause-specific, for hepatitis, it is higher, the mortality. So this is about the hardest outcome that you can have. in terms of health impact, that the mortality due to hepatitis and then secondary hepatocellular carcinoma, which is the result of undetected and untreated chronic viral hepatitis A and B. And so why refugees, and why do refugees, do they have a poorer health status? And from this longitudinal survey of immigrants, that immigrants as compared to other refugees as compared to other classes do have a poorer health status on arrival, and that this declines over time. And so the longitudinal survey was a self-reported survey that was done in 2000 at time 0, at 6 months, 2 years, and 4 years of follow-up. And so you can see that refugees fare worse at baseline as well in follow-up. But as I was mentioning before in terms of the healthy immigrant effect, that if you start thinking about, so how do I address immigrant health and who are the groups that really need to be focused on, you'll see that it's very heterogeneous. That there's differences by age, the greatest advantages for adults, but this doesn't seem to be quite as strong for adolescents and children, and women do fare worse, and particularly refugee women and their children seem to fare worse. So in terms of thinking about health conditions and what are the health issues to be thinking about, these are sort of main categories, and it was just too overwhelming to go through a line list of what are the major health issues in each of these categories, because it is actually it's very diverse, and it depends on where people come from, and it is really driven by all of the different factors that I mentioned. But I do want to highlight that immigrants are at increased risk of infectious diseases, but refugees have particular health disparities related to infectious diseases. They have a twofold higher risk of tuberculosis and hepatitis B, likely related to exposures, HIV also, and vaccine-preventable diseases, a study that we're just completing on varicella, which is likely related to crowding post-arrival, I think. And then non-communicable diseases at higher risk for hepatocellular carcinoma, as I showed you, mental health issues related to the violence and the trauma that they may have experienced, and women's health issues. So refugees are a particularly vulnerable population because of what they have lived through, and they bring the trauma as well as the violence that they have experienced, and which may have put them at risk for different conditions. So I'm an infectious disease specialist and clinician, and I've given you some big picture strokes. But what I want to do is I want to give you a few examples, because I noticed when I looked through the schedule today that there was no content on infectious diseases. So for 5 minutes, I'm going to talk to you about infectious diseases and just give you some examples from the clinic of how does this all apply to the patient. So in terms of infectious diseases, you need to understand what risk people have for infectious diseases. You have to know your geography, and the patterns are very different from the different infectious diseases that people may have been exposed to. So I want to just share a story with you about migration and why it's an important health determinant from an infectious disease perspective and from the other areas of the other health conditions. So this is a 33-year-old Somali man with a 10-month history of crusted ulcerated plaques on the left dorsum of the forearm, and his left leg. So this actually tells you what the diagnosis is. I don't expect you as non-infectious disease people to know what that is, but just to have a differential diagnosis of what's an ulcerated lesion, what could it possibly be? Could it be bacterial? Could it be fungal? Could it be parasitic? But when we're trying to figure that out in the clinic, we have to ask a few questions. And the most important question, and this is what I tell the residents, is you need to ask, where were you born, and where and how have you traveled? Because this will tell you what people may have potentially been exposed to. So this is a story I got from Pat Walker, who is my mentor in migrant health and really the mother of migrant health, and this is a patient that she saw. So this individual was born in Somalia, went to Nairobi, Kenya, and then to Sao Paulo by air, and went overland from Sao Paulo, Brazil, to San Diego through several countries, which was a 3-month period. And this was a rough and strenuous, difficult journey where he slept outside in the jungle and had many different potential exposures, including to insects. And so, very surprisingly, this gentleman had Leishmania brasiliensis, which is not found in Somalia. And this is why you need to know your geography, that this is a disease of South America. And this is transmitted through the bite of sandflies, and this is where he got it. Now, it always is more complicated because he also has risk for other infectious diseases, which he may have acquired in his country of origin, and knowing that Somalia has a high incidence of chronic hepatitis B and strongyloides, and you screen him and you find those diseases that he would have acquired in the pre-arrival. So here you see the pre-arrival determinants where he was exposed in his country of origin, and to a condition that he acquired while traveling. This is another example of why it's important and to understand the conditions that people go through when they transit. So this was a cluster of multi-drug resistant TB that occurred in Europe from the Horn of Africa, and it was a molecular epidemiologic study. And so this was published in The Lancet, and over a 1-year period, there were 29 cases of multi-drug resistant TB. And just for those in the audience, that tuberculosis is treated with 6 to 9 months of treatment with a very high cure rate. Multi-drug resistant TB takes 2 years to treat, very much more costly, and doesn't work very well with a cure rate of 50%. So it's actually a really big issue. And when you have a few cases of MDR-TB, you worry about that because this is going to be a difficult situation. So this story was there was almost 30 cases of MDR-TB coming from Africans from different countries that were reported in 7 different European countries. And from a molecular perspective, they were all the same strain, and there had been recent transmission. So you take that data and then you look at the epidemiologic footprint that goes with it. And so what that was that the trajectory and the migration trajectory from the Horn of Africa is through Libya. And in Libya, there are human traffickers that put these people, that bring them from the Horn of Africa, put them in detention. They stay for a mean of 3 months. In very crowded conditions, and then get put on boats to take the very difficult Mediterranean trek to Palermo and Lampedusa. And so that's all of these people in pink. So 75% of these people had transited through Tripoli and had gone through the Mediterranean route and stayed for a mean of 3 months. And then they had dispersed out from Italy to the rest of Europe. And so presumably these people had acquired MDR-TB in the detention camps in Libya. And yes. And so the next is what happens after arrival, and already the story of what is happening on the border with the U.S. And this is an outbreak of mumps that's outgoing of 900 cases in several different detention centers. And this highlights the pre-arrival issues where people are under-vaccinated, the post-arrival issues of being put in detention and crowding, which is the perfect setup and the perfect storm for outbreaks, and then not providing vaccination afterwards. So that's the source of this. A couple of more examples: a 65-year-old Cambodian male who's unilingual Khmer, who arrives as a refugee in 1979, comes to the emergency room and has hepatocellular carcinoma from hepatitis B. And here the disparity is his increased risk of hepatitis B and the fact that there's no post-arrival screening and his own issues related to accessing health care. A 26-year-old Congolese refugee female arrived in Canada 2 years previously, presents at 16 weeks pregnant, found to be HIV positive, quite advanced disease. On further questioning is diagnosed, was found to really did have HIV during her immigration exam, but did not seek care, was not linked to care. And we know that refugees are at increased risk of HIV and the barriers of accessing care related to stigma post-arrival and potential transmission to others. So what are we doing in Canada? We do have guidelines. Many people in the room contributed to these guidelines. Lawrence Kermeyer has this fantastic resource of how to manage mental health issues in the immigrant population and the refugee population. There are specialized refugee clinics that have come about to respond to the increased health needs of the refugee population across the country, and they are really based on the best practice model of care, which is multidisciplinary with linguistically and culturally adapted care and tailored health assessments. And so this is what I tried to paint the picture for you, the complexity of migrant health. So you can't say it in one word, that there are all of the determinants of the migration journey. And then there are the enablers and modifiers of what we can do in the post-arrival setting, and then how this changes over the life course. And that then determines what kind of health conditions people will have. And so moving forward, in my last few comments, I think that where we need to move forward in Canada is we have made strides, but we really do need to really spend more energy developing linguistic and culturally adapted care, and we do need to have universal free access to interpreters. And this, we need leadership on a federal and provincial level, and we really are missing any kind of Department of Migrant Health at the level of the Public Health Agency of Canada. And if there's going to be any call to addressing migrant health, you need a high level of policy makers who are driving that agenda. And we need more money, so I think that there is someone from CHR in the audience, and really I think that this is, if we're going to address health, we need more information, and I think we have a critical role to play as practitioners to advocate, to push these two agendas. So just in closing, I think after listening to Min and just speaking to other people, that Yen Bui is a friend and a colleague who came as a Vietnamese spokesperson at age 12 and is a public health physician who runs a refugee clinic in Quebec. And Alfonso Davies, if you haven't heard his story, do Google him and just listen to his inspiring story. It makes you cry. Just the resilience and the positivity which of his story, where he was born in a refugee camp in Ghana and now is the sweetheart of soccer in Canada. And I think that this is sort of my parting message to you, is that I think that we have done and we have addressed migrant health issues in Canada and that we've accepted people, but I think that we really are lacking in infrastructure and political will to address this, I think, really on the level that we need to be doing. And now that we have the WHO document that of the promotion for health of migrants, I really think that this is a great document, plus the commission to say that this is, we need to do better.